Good afternoon, everyone. Welcome to the COVID Symposium. I'm Qing Yifeng, the coordinator of the Center for Complex System Studies. Last May, we had a societal discussion on COVID-19 as our very first online event during the pandemic. Today, we're going to have the last event of this academic year, hopefully the last online one, to take a look back at the developments of COVID-19 related research. As the pandemic posed a lot of challenges, we need to view them as a complex system and tackle them with interdisciplinary efforts. We are very happy to have three experts here today to talk about three different aspects: modeling, complexity, and policy. For your information, a call for new collaboration with complexity science, the experts will be pre-released by the end of the symposium. You can also check the link in the chat box. Now I will hand the air over to our director, Professor Henk Dekker, to open this symposium. Henk, please.
Yes, so also welcome from my side. I think, this COVID-19 pandemic is still ongoing. Is of course a fantastic, example of sort of interlinked systems and how they all, influence each other. You've seen, it's transitioned of a virus and has to do with networks of humans who transmit this, and then you have, human behavior, which is important, public opinion, economic and social consequences. So all those sort of systems are affected. And as Tinji also said, we were very interested to have, a sort of view on that now that we're nearly at the end of the tunnel, at least we hope so. To give an overview from three different aspects. And so we have three speakers, Mirjam Kretzschmar, Deb Panja, and Sake de Vlas, sorry. And so I'd like to start with the first speaker, which is Mirjam Kretzschmar, who is a professor of epidemiology at the UMCU, so the medical center in Utrecht. And she will talk about the modeling approaches for assessing intervention effectiveness for SARS-CoV-2 in the Netherlands. Now she's going to speak for 30 minutes. And the idea is that during that time you can already put your questions in the, chat box, but then we discuss them at the end. So there will be 10 minutes discussions after each talk. Mirjam, floor is yours.
Okay, thank you for the invitation. I have an echo. I don't know whether we can change that. Okay, now I think it's better. Thank you for the invitation, and I will share my screen. Let's see. I hope you can see it. So I will talk about modeling. Pardon me?
Cannot yet see it. At least I can't see it. No.
Oh.
Yeah, it's coming.
Can you see it?
Not yet. I only see MK now.
It just worked in the test.
Well, I'll just try again. Yeah, that's coming.
Okay.
Yeah, thank you.
Okay, sorry for the delay. Thanks for the invitation. I will talk about modeling approaches for assessing intervention effectiveness for SARS-CoV-2 in the Netherlands. And as we all know, we saw this already quite from the beginning of the pandemic. Modeling has played a large role in determining policies everywhere around the world. And so these are just some headlines that you see from various newspapers that talk about modeling, the projections and the outcomes of the modeling and how it was used for policy making. You probably all also remember from the beginning weeks of the pandemic, this idea of flattening the curve. So if we can put on interventions, we can shift the peak of the epidemic curve towards the future and also flatten it to make it more feasible for the healthcare system to deal with the pandemic. And so modeling has played a big role in that. And this was actually a first time, let's say, in history that modeling has from the beginning played such a determining role in policy decisions. Of course, modeling has been done already before the COVID pandemic. There has been a lot of modeling for HIV and HIV interventions, but also other like tropical diseases. So our third speaker works a lot on modeling tropical diseases. There has been a lot of influenza modeling. So the modeling itself is not new, but the way it has been picked up by policymakers and media, that was quite different this time. We all know by now what interventions there are for SARS-CoV-2. So we have social distancing measures that are supposed to reduce the numbers of contacts between people. We have hygiene measures like hand washing or mask wearing that are supposed to lower transmission probabilities. We have isolation and contact tracing that is supposed to break transmission chains. And more recently, we also have vaccination that's supposed to lower susceptibility of individuals and therefore generate protection. But with all of these interventions, it's always the question, what's the impact? So before introducing them into the population, can we say something about what to expect of the impact on the pandemic? And to do this, a number of different modeling approaches have been introduced or used. The most well-known approach is the so-called compartmental modeling, the SEIR model, which I will talk more about. So these are deterministic models based on ordinary differential equations. But there are also other types of models, for example, models based on branching processes that describe certain phases in the epidemic when there is an exponential spreading. And finally, more complex models like individual-based models or network models. And the second speaker will talk more on network models, and I think the third speaker, Sake, will also talk about individual-based models, which he's using a lot, but I will also give an example of our work. And in the graph here, you see kind of the increasing complexity of different model approaches. So the most simple compartmental models just assume a homogeneous mixing of the population, but then on top of that, you can put certain social structure that results in non-homogeneous mixing, but mixing, for example, within certain compartments and between compartments. And then a more general type of model is the contact network model, where you really have to define the exact contacts between individuals in a population. As you can imagine, that parameterizing such models is usually quite difficult. And then there are different types of models that look on different scales. For example, meta-population models, where you look at interactions between different populations. And then finally, to really do the fine-grained modeling work with all different types of subpopulations, the so-called agent-based models. Now, just a short historical reminder. This all started with work by Kermack and McKendrick, so two English scientists. They were actually not mathematicians, but Kermick was a biochemist and McKendrick was a physician, and they wrote a series of papers about, they were called A Contribution to the Mathematical Theory of Epidemics, in which they basically introduced what we nowadays know as the so-called SIR model, although in their original paper it was already much more sophisticated than just a system of ordinary differential equations. For COVID-19, it's usually used in this form, the so-called SEIR model. So it has also a compartment for exposed individuals. So we have susceptible individuals, exposed individuals, infectious individuals, and immune individuals. And the model describes the numbers or densities in these compartments and transitions between those compartments as a system of differential equations, as you can see here on the right-hand side. And the main feature of this system of ODEs is that there is a nonlinear term here describing the transmission, which leads to the specific epidemic behavior that this model describes. So one of the concepts that was also already introduced by Kermick and McKendrick is the so-called basic reproduction number, which is a threshold quantity, also called R0 or R0, and it determines whether an epidemic can spread in the population or goes extinct. So if this R0 is larger than 1, the epidemic can spread. Every infectious individual replaces himself by a new or more than one new infectious person, while if this R0 is smaller than 1, then the transmission chain will die out and the epidemic will stop. And so this is the basic reproduction number, let's say at the beginning of the epidemic when the infection starts, but one can generalize this concept also to a time-dependent reproduction number, which we by now all know from the RIVM dashboard, where this quantity is estimated regularly, and we see how this reproduction number changes over time and basically how many, on average, how many new infected persons one infectious individual produces. And so if this is larger than 1, we have a problem, because then the number of infecteds will increase. If it's smaller than 1, the epidemic is under control. Now, to say a few things about the epidemiological characteristics of COVID-19, because they basically determine how successful we can be in controlling. So there's an incubation period of around 4.5 to 5 days. Incubation period is the time between acquisition of the virus and symptom onset. Then there's a latent period, which is around 2 to 3 days, and this is the time between acquisition of the virus and becoming infectious. So you see here, and this is one of the big problems of COVID or SARS-CoV-2, that people on average become infectious already before symptom onset. So before they actually know that they have this infection, they can already transmit to others. The infectious period is in total around 10 to 14 days, and infectivity is highest around the time when symptoms start, and then it decays. So around this time of symptom onset, the highest number of secondary infections are generated, which means that around 40% of all transmissions actually already have taken place before symptoms become apparent. Another important feature is that infections can remain asymptomatic or very mild, but even then a person can transmit to others. So that's also a big problem, because it could be that people don't get tested or aren't really bothered by being infected, and they can transmit to others. There are estimates for R0, so for the basic reproduction number for COVID. This is from a meta-analysis based on Chinese data, where the pooled estimate was around 3, so 3.3. But estimates also from other countries are in a similar range, so between 2.5 and 3.5. Of course, yeah, so this was for the, let's say, the original variant of the virus. Now we have seen a few other variants that have higher reproduction numbers. For example, the UK variant, or nowadays called, I think, Alpha variant, and the Delta variant, that both have higher reproduction numbers. Okay, so why is this interesting? So if we look at the combination of these parameters, on the one hand, how many infections are caused before symptoms occur, and what is the basic reproduction number, these two together actually determine how well controllable an infectious disease is. And here on the right-hand side, you see a graph taken from a paper by Christoph Fraser from 2004, so way before SARS-CoV-2, and he plotted the location of various infections within this plane of, on the x-axis, proportion of infections that occur prior to symptom onset, on the y-axis, the basic reproduction number. And I plotted here SARS-CoV-2 into this graph, so you see it's kind of in the medium range of controllability. It seems to be better than HIV, where most secondary infections are actually occurring before symptom onset, but it's harder to control than the SARS virus that we had in 2003 from the first SARS outbreak, but also smallpox, which did have a higher basic reproduction number, but hardly any transmission before symptom onset. Okay, now I want to show you two examples of studies that we did in Utrecht, and these are my collaborators. And you see we have a member of the OMT, so the advisory board for the government in our team. So we were kind of in direct contact also to the OMT. And so some of our modeling also had some influence. Well, when Deb actually asked me to talk, he said, well, can you maybe talk about the RIVM models? But the problem about RIVM models is that they are not really, let's say, openly available. So this is from a report that was published by the RIVM, and under the heading are the code and the data on GitHub, it says, we just give you the type of the model, SEIR, and everybody can then himself write the code or in his or her favorite programming language. Or if you want to have it quicker, you can actually look at models that other people have developed. And here they named the model that we developed in my group in Utrecht. So that's the model that I'm going to show you a little bit. And this model is publicly available on GitHub and has also been published in Nature Communications recently. So actually, when we started this modeling work, this was already back in 2020. I think we started around May 2020 with the idea that we wanted to model exit strategies from the lockdown at the time. But as this modeling work has taken quite some time to get the model fitted to data and so on, by the time we then had it ready to actually look at questions that were there at the moment, we were in autumn 2020. So that was the time when the second wave just started, and the question was, should we close schools as an intervention measure? And so that were the questions that we looked at with this model. We wanted to understand what's the role of school-based contacts in the epidemiology of SARS-CoV-2 and yeah, what are the effects of school-based and not non-school-based measures. So we used in a sense also an SEIR model. It was somewhat more complicated because we also had hospitalized people in it, and more importantly, it was an age-structured model. So we had age classes, and we also looked at different susceptibilities. So we assumed that children were less susceptible than adult individuals, and these were less susceptible than elderly individuals. And we had 10 age groups, and also hospitalization stratified by age classes. And this all because we wanted to use age-structured hospitalization data to fit the model. Yeah, then, but again, it's in a sense a simple model because it's a set of ordinary differential equations which look similar like before, only they have a lot more indices and the number of equations is much higher, but otherwise it's basically the same. Well, what we did now need was information on actually mixing between the different compartments, so mixing between age groups, for example. And we used here data that was collected by RIVM and published in Eurosurveillance. So there were contact matrices that describe numbers of contacts by age, so age of participant and age of contact from before the pandemic, and after the first lockdown. So that's data from March, April 2020, when there was a maximum reduction of contacts. So in total, 71% reduction in contacts. And this data was also stratified. Now, the data before the pandemic was stratified in different types of contacts. So there we had, for example, information about how many contacts are there in schools and how many contacts in other locations or other age groups. So we could use this data to parameterize the model, let's say, without any measures and for a full lockdown. And we then took linear combinations of these contact matrices to describe the transition from before lockdown to lockdown, and also to opening only schools or reopening or relaxing other measures. This model was then fitted to various data sets to, on the one hand, age-stratified hospital admissions within a certain time period and age-stratified serological data. So that was data from April, where still quite a low number of people in the population were actually seropositive. And this was done in a Bayesian framework using STAN. That's a software package for data fitting with an R interface. So what you then get is parameter estimates for the various model parameters. I just show some examples. I don't want to go through it in detail, but basically you get posterior distributions for all the parameters that are estimated. So, for example, also for the age-dependent susceptibilities, for age class 0 to 20, it was 23% relative to 60-plus-year-olds, and for the adults, it was 61% relative to 60-plus. And this agrees with what has been observed in empirical studies, as, for example, in this reference given here. This is an estimate of the probability of hospitalization per age class, which also agrees with data as observed. So low hospitalization rates in younger age classes and then increasing in adult age classes. Here you see the model fit. So this is the black curves and the gray shaded area. This is the distribution of the model outcomes, and the red dots are the observations for various age categories. And you see that overall there's quite a good fit of the model to this hospitalization data. And similarly to the seroprevalence data. So here again, the red distribution plots are the model estimates, and the black dots here are the data. Okay, so then we had the fitted model, and we looked actually at various time points with respect to measures. So we have here point A is before any measure, so beginning of the pandemic. Point B is the full lockdown in April 2020. Point C is the situation in August 2020, before the second wave started and when schools were just reopening after the summer holidays. And the last point is November 2020, when the second wave had started. And the question was, should we close the schools again? And for all of these time points, we could determine the effective reproduction number based on our model parameters. So then we looked at what would various combinations of closing schools or reducing other non-school contacts do on two time points, namely August 2020 and November 2020. Okay, so in August 2020, we saw that reduction of other contacts would bring down the RE to about 0.8. So this would have prevented the second wave, while not opening schools would have brought down the RE to just around 1, so it wouldn't have really prevented the second wave. In November 2020, then the RE was already around 1 because of certain measures that were already in place. So then going to the full lockdown would have again brought down the effective reproduction number to 0.8. But closing schools would also have been able to bring down the RE to below 1. So, so it could help in this situation to get the second wave under control. And that was also then what was actually decided by policymakers. We also saw that older school children have more impact on transmission than the youngest ones, so the ones between 0 and 5. So that also makes sense. And yeah. Now we are a few months later. Now schools are being reopened, and we got the question, what can we do that reopening of secondary schools doesn't lead to a new wave of transmission in the population? And so this is new work by a PhD student of mine, Thi-Mui Pham, together with a team here led by Patricia Browning, whom you probably know from various TV shows. And we just finished this report on this individual-based modeling. So this was a question that had to do with really small-scale modeling within a school and looking at what would certain intervention strategies like testing strategies have for an impact on transmission within a school. So in this case, we chose to do an individual-based modeling approach because we also had actually data on the contacts within schools. So the question was, what's the number of school-related infected individuals for certain situations? and how can we reduce it? And we wanted to compare various strategies like risk-based testing, screening, that's regular testing, and quarantine and vaccination of teachers. And so we were in a good situation that we had a pilot study where contacts within schools were actually being monitored, and these testing strategies were tried and registered. And so we generated this model that looks explicitly at teachers and students in schools in various time steps. So the time steps were within 8 hours. She included within school contacts, outside school contacts, night hours where there are no contacts, and also difference between weekday and weekend, and introductions from the community into this system. And we looked at how many contacts and infections would there be within 1 month. So we had this just an example of the type of data. So we had for a number of schools data on contacts of the students split up by grades and by whether the contacts were within a class or with students in the same school outside of the class, and also between students and teachers. And then we looked at various strategies like half occupancy. So this was the situation up to beginning of June, then where secondary schools only had half of the students per day coming actually for physical education into the school. And we looked at what would happen if we would reopen schools fully. What would vaccination of teachers have for influence, screening twice weekly, and combinations of these strategies. And using this model, we could then calculate numbers of school-related infected students and teachers. And you see here, well, these are, let's say, per school, of course, quite low numbers. So the risk-based testing for half occupancy, they have almost no risk. But then if you go to full occupancy without any additional measures, you would increase the risk considerably. And then there is a reduction for these other intervention possibilities. And we looked at this in various ways. So here, for example, on the x-axis, you have the number of introductions from the community and to how many secondary infections in the schools would this lead. And the idea was that if this number is, let's say, above the diagonal, it would mean in some sense that the schools are amplifying this number of infections that come from outside. And then we kind of roughly added this up or extrapolated to a large number of schools in the Netherlands. And basically the main conclusion was then if we implement 2 weekly screenings or twice a week and the adherence is high, then the risk for the students would be, of course, somewhat increased, but not too much. And the risk for teachers would be basically not increased, while, some of the other interventions did not lead to such good results. Of course, if you would vaccinate the teachers, you would be able to reduce their risk of getting infected. That's quite logical. And we also saw that this intervention effectiveness of the screening depended a lot on the adherence. So if the adherence is lower, then there is still quite a risk, but if adherence is here around 75%, then this is quite a good intervention. So that was basically from this study, our main conclusion, screening twice weekly can be effective in reducing infections in students and also in protecting teachers if the adherence is high. And yeah, so that's also then what Minister Slob said and announced, that if only 50% of the students do the self-test, then it's already quite good, and the schools can be opened quite safely if students test regularly twice a week and if they adhere to this policy. And so that was the decision. Yeah, so with that, I come to an end. I thank you for the attention, and I'm happy to answer any questions.
Yeah, thank you very much.
Share my screen.
So let's see, is there any question? I see Dirk Schuricht. Go ahead, Dirk.
Yes, I would like to know, let's say, having in mind an experimental setup, I would like to know to what extent do your estimates and conclusions and so on depend on the quality of data you put in? Do you have any idea how good the data is that you use to kind of start?
Mm-hmm. Well, we have different types of data, of course, and I think they have different qualities. In the first modeling approach that I discussed, we used hospitalization data, which I think is quite good because hospitals have good registries, and this has been communicated to RAVM regularly. So I actually think that these data are quite complete. Seroprevalence data, I think they are also quite good because they are based on an representative seroprevalence survey in the Netherlands. So let's say they are as good as they can get. And then, of course, we have the data about the contacts, the contact matrices. To collect that data, you rely on surveys. So there people are asked to record, for example, for a specific day, how many contacts did you have with people of a certain age group on that and that day. And contact is then defined as being somebody who you've talked to within a short distance for a certain minimum amount of time. So yeah, so that's of course we don't really know how reliable these data are. What makes us trust in these data is that similar surveys have been done in many countries, and they all get to kind of similar, in at least let's say qualitatively similar types of structures with high diagonals, so a lot of within age group mixing and lower outside the diagonals. But yeah, how they rely on self-reporting, so there's always an uncertainty factor.
But maybe let me ask specifically. So let's say your main conclusions don't depend very sensitively on kind of the precise numbers you would put in. I mean, you would be worried that when it has to do with exponential growth or so, that the change of a parameter by whatever 5% may already have a big.
Well, no, I think there I wouldn't be too worried because, I mean, we don't model only exponential growth. I mean, we also modeled, so we fitted to the data for the whole period of the first wave, which includes also the decline. So that, but I mean, I agree with you that if you have only, let's say, if you're at the beginning of the pandemic and you have only data from the first initial growth phase, then the uncertainty can be quite large, and the further you get into the pandemic, and especially if you then also have already the peak behind you, then it gets more reliable, I think. But yeah, there remains, of course, uncertainty.
Okay, thank you.
Next question is by Rembert. Down.
Yeah. Hi, can you hear me?
Yeah.
Yes.
Yeah. Thanks for your nice talk. I have just a basic question, not necessarily about COVID-19, but just about let's say epidemics in general. So the R0 number, or equivalently your I think your beta and gamma in one of your models. So to which extent? So I assume that in part they depend just on let's say the virus itself, but also in part they may depend on the type of society, to put it like that.
That's
So
absolutely true.
So how sensitive is that latter dependence in particular? So if I would compare, let's say, Japan to a Mediterranean country or so.
Yeah, I mean, I showed you these estimates for R0 for COVID. They were all based on various Chinese populations or studies. I mean, I don't know, I can show this again. I mean, there you already see that there is quite a let's see, that there is quite a variability in these estimates. And if you look at more or different populations, so it depends on the one hand on the virus characteristics, like how long is the infectious period and how high is the infectivity, but to a large extent it also depends on the contact patterns in the population.
Right.
But it depends on, let's say, on the studies that actually make these estimates, or what kind of studies are they, how do they collect this data, and what kind of statistical methods do they use to estimate these numbers. But so in a sense you have to take this estimate with a grain of salt, but as you see, it is all around, let's say, a certain average number, but there are of course variabilities, and this is also, I mean, if you look at other diseases like influenza, these variabilities are even larger, or also for measles you have many different estimates for R0. So in a sense it's a bit maybe a qualitative estimate. You have to, so we can say, for example, that the R0 for measles is much higher than for SARS-CoV-2, but we can't really pin it down on a very precise number.
Okay, clear. Thanks.
Thank you. I see there's one more question, but I try to be a good chair and to be on time. So I'd like to thank Mirjam again for this very nice talk. And then we'll go on to the next speaker, which is Dr. Deb Panja, who is Assistant Professor of Simulation of Complex Systems at Computer Science Department at Utrecht University. And he will talk about modeling of SARS-CoV-2 transmission in the Netherlands with an underlying dynamic network. Deb, go ahead.
Yeah, I am just trying to figure out. Yeah, there I go. And then I have to share. You can see my slides?
Yeah.
Laser pointer. Yeah, great. So you can also see the laser pointer?
Yeah, very
okay,
nice.
Thank you. Yeah, well, thank you for, I think I'm supposed to give the presentation on the complexity side, so I feel a bit odd to say that, well, thank you for inviting me, because I am one of the insiders for Complex Systems Center. So I think I would like to actually start by making the disclaimer that I am not an epidemiologist. So I try to work with epidemiologists like Mirjam and Sake, who are my close collaborators now in various circumstances. And the particular aspect that I would like to emphasize is this dynamic network. In fact, that is basically what you see. And how Mirjam has already given a very good introduction on the general epidemiology, and I will take it from there. She has also mentioned about the network and individual modeling, and I will take it from there to on this individual modeling and see how we can scale it up to actually we do in the end 1 to 100 ratio for the Netherlands, and that's like 170,000 people, a purely agent-based modeling. So let me get started. So one advantage, of course, is that because I'm not an epidemiologist, I can take a distant view of the field. The other, of course, the disadvantage is that I do not know enough of the epidemiology, so I hope that I will not make wrong statements. But in any case, there is Mirjam and there is Sake, so they can happily correct me. I'll not be offended. All right, so network epidemiology. So network epidemiology is not such a young field. I mean, it's been I would say about 2 decades old, and certainly much younger than the epidemiology field as such. So let me just give you this little picture. And what you see is a network of people's contacts, and you can see that this is the source of the infection. So someone who has been infected with something is passing on the infection from here to there and there to there, and then from there on it propagates. So this is as simple as it is. And for example, if you take this one, this particular person, then the force of infection on this person can be exerted by the originator of this infection, or for example, someone who has been secondary infected by the originator. So even though it actually looks rather simple and rather trivial, I would say, what it helped us to do, thinking about the network, is a separation. And this is something I always emphasize in my presentations or talks or discussions, is the separation between the network and the process that plays on the network. So the network is purely built of people's contacts. So this is how we interact in the society, and we build contacts, friendships, and all of that. And pathogen, or fake news for that matter, uses that particular network to spread. So network is behavior, and the other is the process. The spreading is actually the process. So this is something, a red line that I will continue to hold. Now, what happens for dynamic network? Well, here is a classic example. Real life is clearly not as simple that we are forever in contact with everyone else in our society. So if someone starts the disease, it will just continue to propagate as long as we are basically all exhausted or have immunity of some sort. So here is this one of these runtime examples. So there is one person who is coming from Leiden, a student, let's say, and eventually is a Hogeschool Utrecht student, and traveling by train from Leiden to Utrecht. And there is someone who comes from Gouda, also comes at Utrecht Central, and then they take the bus. And both of them share the bus ride, which is about a little over 15 minutes, let's say, for the tram ride to Eindhoven. And they're within 1.5 meter distance in the context of SARS-CoV-2. And because of the way the virus transmits, it is quite possible that this particular person has been infected, although he or she doesn't know about it until the moment. So by the time he or she steps out of the tram, it's already infected, and then goes on to the work at Minette Cabau. So this particular part of the network, it comes out of people's daily life and the way they organize that. This network contact, or the part of the bond of the network, or the link of the network, only exists for that 15 or 20 minutes of the bus ride. And it may very well happen that this person and that person will never ever meet in their lives again. So basically, it's a complication from the static network like this to a dynamic network. Okay, so what are the consequences? Well, the clearest consequences is that there's an arrow of time. So if A is the initiator, it can infect B, and then afterwards can infect C. And this is, well, A can certainly infect C, but the reverse is not possible. Well, it might sound like a rather trivial thing, but if we can, now that the computers are much more powerful, if we can take these things on board, we can have a much more complete model of the dynamics. So let me then go on to give the take-home message from the network epidemiology, the story that I said in the last slide, is that, well, so this is the static network way of looking at network epidemiology. So I have a static network backbone. Topology never changes, and the pathogen transmission is a dynamic process that is playing out on top of the backbone. And that will still be the case, except that this time, well, this is the summary of the fixed network, what I just told you. And for the dynamic network, what's going to happen is that the topology of the backbone will change in time quite rapidly, and taking that into account matters, really matters. And that's one of the examples I gave for this two people, one coming from Leiden and another coming from Gouda. So if you actually look at this picture, you can very clearly see that the contact network is heterogeneous. And what happens is that a dynamic network is also temporally heterogeneous. So if you plot these contacts of people, it keeps changing in time, and that introduces also a temporal heterogeneity. And of course, you have to obey the interaction sequences, which I also mentioned, that A to C and then backwards in time to B infection is not going to happen. However, it all sounds very nice and it's possible to do and so on. However, one has to be very careful about what one wishes for. And then if you let's say strip apart the process and the network backbone, then the disease dynamics becomes a combination of two things. One is the network dynamics, and that is purely the behavioral stuff. And then a pathogen transmission as a stochastic process on top. And here will come all kinds of timescales related to incubation period and how long it takes for the person to be asymptomatic and how long it takes for the person to be infectious and these kinds of things. So eventual dynamics is a combination of the change in topology or the dynamics of the network topology, as well as the internal timescales of any kind of transmission. It can be fake news or it can be something else. That we have to be very wary of. Right. So let me then give you a full complexity view as I actually see it, epidemiological dynamics. And Mirjam basically spoke about this side, which is the population level. And as you see, there is this SIR. These are the compartmentalized models, and I'll come to that in a moment. And this is the part which is the micro or the meso side, if you like. So behavior plays a very big component of epidemiology. And in order to break the transmission chain, you can do it at two levels. One is at the really individual level, and that means wearing masks, washing hands, vaccinations, and so on. And then the interaction part, that by which basically all the infection actually spread. If you combine all together, some sort of coarse graining. So let's say this is the micro and the meso level here. And after coarse graining to the population level, a huge coarse graining, therefore, you get to the population epidemiology, but it also has a feedback. And the feedback to human behavior is, for example, if I know that there is a pandemic going on, I would be careful. And that feeds back on this one. And similarly, if something like this happens, then there is policymaking that gets involved. And Sake will talk about this, and government will say, well, we have to put all these mandates, we can close schools or supermarkets, etc., lockdowns, night curfew, and that will also have an influence on human behavior. So it's a gigantically complex problem that we are trying to solve with all the scales of aggregation in space, time. I mean, space, I think you should consider it as individual, so individual based all the way to the population level. But at the same time, there are all these feedbacks that are also going on. So in that sense, it is a complex adaptive system. If people who follow the complex system language, you will immediately see that this is a complex adaptive system. Okay, so let me just go back with that full picture to what I wanted to say in terms of the compartmentalized models, and Mirjam has already given a very nice introduction to that. And why are they called compartmentalized models? For the joke, I actually like to call them as bucket models, because basically what it does is that it breaks the population down in buckets. So the susceptible bucket, the infected bucket, and the recovered bucket, and the rates, if you write it down in terms of the differential equation, then you have the beta and the nu. Well, sometimes it's also gamma. I do the SIR model. It can be much more complicated, as Mirjam pointed out. And then there is this R0, which is then the ratio in SIR model as beta over nu. So as you see that within the bucket, it is homogeneous. So this is a level of aggregation, highest level of aggregation that for the population. Now, if you want to increase the number of amount of heterogeneity, you can consider subcompartments. So compartments like the age stratification is a subcompartmental, but it is still a form of compartmentalized model. So you can increase the capture more and more heterogeneity, but by including this sub-buckets or the subcompartments. In contrast, the network models, they will respect the SIR compartment. So first, this part I'm actually going to talk about only the fixed network bits. And in the fixed network, what is done is that the subcompartments are are defined in terms of the degrees of the agents. So if you look at this particular, well, I think I have to go back quite some slides, but the degree of an agent, which is a node in this network, is simply how many other nodes it is connected to. So you can then you can have an S of k and I of k and R of k, or the other way around, and then you can have these bucket models again. So it is the static network models are simply an extension of these compartmentalized models, but done in a different way. Now, question mark is, how are we going to do this in terms of the dynamic networks? Right. So here is the picture. One back to this full complexity in full glory picture. And what I'm going to do is, of course, I'm not going to be able to solve all of this, because that is a multi-year project and multi-people project and so on. If eventually it will be, but I'm going to take only this part and demonstrate to you what we are currently doing in terms of a small funding from NWO. I'll show it in a moment, how to use the social interactions. People travel for work, they travel for social visits, they travel to supermarkets, and so on and so forth, and they interact with each other, and how that can be captured. That is basically what I'm going to talk about. Right. So first of all, again, this is my title slide. Back to that with slight modifications. It's an ongoing work within Complex System Center, and the two people that are involved in this is Mark Dekker and myself. I'm here, and there is also Luc and Sake from Erasmus. They are let's say the policy plus the epidemiology side that are helping us. And Frank Pijpers is from CBS, who's helping us with the data. And as I said, this work is being funded by an emergency funding from Zone MOE 2020. Formally, the project has already ended, but yeah, you know, it was a one-year funding, so we got a small amount of money to do this. It was the funding was obtained by Hans and Mirjam, whom both of us, well, we all know them as the leading epidemiologists in this country. But the paper is not yet published, and I think it will be about a month before we can get close to submission. Okay, so with all that introduction, let me now start to go into the details of how we do things. Right. So what we are going to do is obviously modeling the SARS-CoV-2 propagation in the Netherlands, and the dynamic network is going to respect the S, E, I, and R compartments, and Mirjam has already spoken about it. The compartments have subcompartments, and these are tagged by Gemeentes and its stratification. So how does that work? We have discrete agents. And discrete agents are taken at 1 to 100 population ratio, so there are 170,000 individuals that are in the model. They are tagged by their gemeente residency. So if someone lives in Utrecht, but because of work reason travels to Amsterdam in the first half of the day, then goes to Gouda for another 2 hours, and then returns to home. At the end of the day, in the end of the workday, then this person simply carries the label of his or her gemeente residency with him or her. And also, of course, AHU, the person is clearly carries with him or her. This is, we are going to, what we are doing is that we are calibrating that to the demographic data. This purely comes from CBS. And then what we are going to do is that this movement that we are going to implement is an hourly data, and that is also calibrated against hourly mobility data from CBS and Missouri, which is a kind of an umbrella organization for the mobile phone signals, tracking them in a very aggregated way. So it is not that we are tracking individual people, and the data the available that we have is only from before the pandemic started. So we cannot predict or we cannot simulate a situation when during the second wave, because that data simply we do not have. So we can essentially simulate or look at do all kinds of in silico experiments about what would have happened if people did not change their behavior, and then we can play with what kind of intervention measures could be effective, and so on. All right, so time to show some graphs after this. Again, this disclaimer, all data and plots in the following slides are preliminary because the work is not finished yet. As I said, it will take about a month before it is all done and finally sent off for publication. All right, so so first, again, going back to the network epidemiology, first we are going to build the dynamic network, or at least demonstrate how it works, and only then put the process on top, the epidemiological process, that is. So here is what you see is combining the individual mobility and the temporal heterogeneities, obeying the age stratification on a Gemeente basis. So that's the lowest scale that we go up to the Gemeente. And so if you look at, so these are samples taken from 30 people from The Hague, and you can see that most of the crowding, so this is the time of the day from 12 o'clock to 12 o'clock in the night back to 12 o'clock. And most of the movements are happening basically around work. This is a typical work day. If you take, for example, this take red line, so there are some people in the red lines who just remain in that Gemeente all through the day, and this other person who is traveling, let's say around, I would say 7 o'clock, travels to Rijswijk and then stays in Rijswijk until, let's say, 2 o'clock. And then from there on travels to Leidschendam, Voorburg. I'm not sure if you can read this very well, and then goes to Delft and just at 5 o'clock, and then returns home at 6 o'clock. So this is from the middle-aged working group. And similarly, if you look at 30 people from the preschool children from The Hague, there you see that most of the people actually go to school to Rijswijk, and some people go to some kids go to Pijnacker, Nootdorp, and to Wassenaar, and these kinds of. So they don't travel as far. It's the working group people that are traveling the most. All right, so. Again, to remind you once more that these buckets are really the Gemeentes, and people are traveling at an hourly resolution, 170,000 people all over the country. They take their labels of residency of the Gemeente with them, as well as the age. Right. So if you aggregate all of that over a workday, then this is, for example, in aggregated primary contact among 170,000 people. So basically, this is the kind of thing that you see. So aggregated over a given workday, the contacts between different across age groups. So middle-aged working versus middle-aged unemployed. That's the thickest line over a working day. Then middle-aged working to adolescents. I mean, thickness of the line tells you all over the entire country averaged. And similarly, you can also aggregate the data over Gemeente, and this you can see that most of the travel is actually happening, contacts are actually happening in the Randstad area, and big cities you can see like Groningen here, you can see Leeuwarden and Amsterdam and Utrecht and Eindhoven. You can see these classic travel patterns. Right. What we can also do is this kind of thing. So once we know this 170,000 people, we take samples from which obey the CBS and the mobility statistics and the age stratification and so on. We can try to find out. So suppose there is a person who is from The Hague and has gone over a travel day, over a typical travel day, over multiple Gemeentes, and then we can see what kind of contact this person makes. So what we are going to show here is that every time this person meets another person, so let's say this particular person from The Hague is to start with, you give it a red color, and what happens is that if this person meets another one which doesn't have the red color, then they will become the new person is also going to become red. So first, and then that process just goes on. So the paint, let's say the red paint, just keeps spreading. And this is something we informally call contact spreading, or the potential sequence of contacts. Why potential? Because, of course, if they're in the same gemeente, then we cannot distinguish what happens microscopically within the gemeentes. We assume that there is a possibility for these gemeente to slowly turn painted. So this is a simulation of over 240 hours with hourly resolution. And the first things that you see, well, here the color is not very obvious. And within about 18 hours, you can see that the red paint has kind of spread in this region and to Amsterdam, because that's the mobility part. And then Utrecht slowly starts to get colored. Then you can see Eindhoven, you can see Groningen, and slowly in a matter of about 240 hours. So that's about 10 days. If this mobility pattern continues to hold, essentially every person has come with a person that is in contact, has been a contact with a contact with a contact with a contact to the original person from The Hague. So you can see why contact tracing is so difficult and so expensive to do. All right. So this is kind of where all the framework for the dynamic network kind of stops. And after that, we are going to put on the epidemiological process on top and then see what happens. Infection as a process on the network backbone. So again, we do SEIR model, and I'll essentially ask you not to pay any attention to these things. So there's a gemeente level, and there is a age grouping, and there's of course time and so on. But just to show that we are doing our homework correctly. And then there's this parameter beta 0, which is why I actually wanted to show this. This is the only free parameter in the entire process, and this free parameter we set by fixing it or let's say matching it to the R0, and we take the R0 to be 2.5 for the Netherlands. If you have a different R0, fine, we just change the corresponding parameter beta 0 and then run the same model over and we'll produce the results. So all runs are stochastic, and only after you have run a couple of times, then you can start to take average, and then the averages will start to make sense. I think at least from the physics background, you will understand what this is that's all about. All right, so if we now have this mobility patterns and so on, and we know who contacts whom, and this, if you take a typical weekday in Eindhoven, then within that gemeente Eindhoven, you can see the amount of so-called infection pressure, and this infection pressure basically means a typical person, how much infection, what is the likelihood for this person to get in this age group to get infected. Well, you can see that this is the darkest, and by the way, the thickness of the line and the color of the line are basically indicating the same thing. So it has the most risk from higher age working, and lowest risk from the preschool children. So these kinds of statistics you can build from the model. And what is important to note here is that this will depend on day to day. So weekday will be different from weekend, and Eindhoven will be different from Groningen, and will be different from Utrecht, and so on and so forth. So all the spatial and the temporal heterogeneities are now captured in this model. And so this is actually, this work is again as mentioned together with Sake, and Sake has mentioned that it would be interesting to see, because to see the onset of COVID for the first wave, and to see how it actually really matches the data. So this time we put the first outbreaks in Brabant, because that's where it happened during the carnival time. And with the correct parameters, basically you can see that, well, this is the start here, and then it slowly starts spreading through the country, and up to 200 days. And according to Sake, who's basically guiding us to the epidemiology side, he says that, well, the model actually does make sense, because we know that roughly it takes about 6 months for a wave to die down. So the timescales are pretty reasonable. So you can read all the susceptible and infected percentages in these according to the from the time passed. Right. Then this is actually my last slide, because in the end, epidemiologists would like to know what kind of intervention measures that should be taken, and it's all about flattening the peak. So we look at four possibilities: no intervention, closing schools, reduced travel, and social distancing. And what you basically should focus on, these are curves that are present in the graph. Of course, we are not going to make new graphs for the presentation, so just show what we have. The main focus should be on this one, and here you see that the 6.3% population will be infected if there is no intervention before this naturally dies down. And then closing schools, in fact, doesn't seem to have much of an effect. Yeah, this is within the error bar, if you like. And then if you have the reduced travel, then it has quite some effect, the 4.7%. And of course, the social distancing, that has the maximum effect, because here you have a peak of 1.8%. So anyway, this is an example calculation, and I would again urge you not to take these numbers and the details of this graph seriously, because this is ongoing work. It will be refined in the coming month. And yeah, once, of course, the paper is written, then they can be taken seriously. Well, then that is my conclusion page. In fact, most of it you have seen before. So the model, the dynamic modeling, dynamic network modeling of the pandemic. So the process is that it respects the S, E, I, and R compartments, and compartments have subcompartments tagged by Gemeente and its data, because this is basically what the epidemiologists would like to know for intervention measures, for example. So what we have done is that we have used discrete agents tagged by Gemeente, residency, and age stratification, proportionately represented by 1:100 population ratio, and it's calibrated onto the Netherlands demographic data, and also calibrated against the hourly mobility data before the pandemic. So we cannot, once again, with this data, we cannot, let's say, simulate a process during the middle of the pandemic. We can regenerate, therefore, only the first wave and evaluate the effectiveness of the intervention measures, provided that people adhere to the intervention measures. So with that, thank you for listening. And I should say that Chinchi mentioned that we see the light at the end of the tunnel, and I hope that my talk has not turned it around to make it appear as if we are seeing the tunnel at the end of the light. Thank you.
Thank you very much, Deb. Very nice talk. It's really the spirit of complexity modeling, so fantastic. I guess there will be questions from the audience. I don't see anything in the chat yet. Yeah, there's one from Rob de Boer. Go ahead, Rob.
Hi, Deb. Thanks. Nice presentation. I was wondering, while you were talking, how do you validate a model like this? You're trying to make predictions, and so then everything that you put in the model is realistic, but still it could be that you're missing out the things that you haven't thought of. So one question that I had, you showed this spatial spread over the Netherlands, and you said the distance of the spread is sort of in agreement with what we know. But it's also the spatial pattern that you generate, like it's going to Amsterdam first and to Groningen later. Is that a way that you could use to test two data and verify assumptions in the model?
Yes, this is in fact one of the things that we do, and I think I would probably deflect the question to Sake, because I think this is an epidemiology expertise that I do not have. Sake, I think you had made quite some remarks during our meetings.
Sorry, can you please indicate? So it's about the validation, right?
Right. So can we use the timescales and the length scales of which, let's say, one of Rob's points is that how do you validate the model in the sense that you show that it appears in Groningen later than in Utrecht, for example? Can you use these kinds of anecdotal evidence to calibrate the model?
I'm afraid that this is impossible. So you have to find a kind of summary measure because one way or another, a lot of coincidental events have played a role, especially regarding introduction of new infections. So you should find a way to categorize different areas as certain types, like big cities, remote big cities nearby, rural areas far away, rural areas nearby, and try to find out if that is mimicked correctly. But if it is Groningen or Leeuwarden, that's too complex, and that will determine on a lot of random events. So you cannot use that detail for validation.
Yeah, but that was just basically an illustration. But see, if you categorize too broadly, then probably you're going back to the same predictions as a homogeneous SAIR model would do. So how do you validate the predictions on top of these sort of simple, well-mixed models? What properties of the model? But you gave me a sort of answer, because you say I look at big cities and I look at suburban areas. That is something that you cannot do in a homogeneous model. So that is an answer to my question. Yeah.
So if you want to capture indeed the spatial homogeneity as well as temporal homogeneity, although as Sake just pointed out, you cannot really use it to, let's say, that the model parameters are valid and so on. This is kind of the anecdotal as far as we can go in terms of phenomenological similarities. But I should also say that there is exactly one free parameter in the problem, which is this beta 0, which is tuned up to R0, and other than that, there is no free parameter.
That's one of the strong parts.
Yeah, but it doesn't mean that the model is correct if all the parameters.
That is absolutely true.
And another way to do some sort of validation is to compare different situations, let's say different countries. Ideally, we would be able to compare different regions of the Netherlands, but the policy has been the same throughout for the entire country, basically. So that also doesn't really offer material for validation, but perhaps a comparison between countries at a later stage with different interventions could be helpful as well, but that will take some time.
Yeah. Okay, thank you.
Thank you. The next question is Roland Giraerts.
Yes, hi. So thank you very much for your very interesting talk. I'm myself in a research project where we also study how the virus can spread in indoor and sports environments. And then we look at how crowds move and also at the level what the effects of the wind, etc. is. And we see that those factors, so how crowds spread, what kind of routes they take, how they interact, what their social distances, etc., are factors that are very important in the spreading of the disease. So is it possible to take these more micro or mesa levels into account in your model? Because
Absolutely.
I think you should, otherwise it's really hard to make good predictions.
Yeah. Absolutely, it is possible, and in fact there is a parallel line which I have not spoken about here, and as soon as you have, like when I saw Mirjam's presentation about schools that she was trying to do, then immediately reminded me of some school data, existing data from schools in France, for example, publicly available data sets which we are working with. And as soon as you have the small scale, it is many more things of this detail becomes possible to do.
Yeah, and then I also had a question about the validity of the models, because a very small change like opening all windows can have a big effect on how the virus spreads or not. So how are you going to deal with all those butterfly effects that can make changes in the results?
Well, not because if you think of the SAIR model in the highest level of aggregation, then these effects are not. I mean, they are not captured. They are too microscopic to be captured here. It's like we do not have super spreader events captured in the model, because these are some things that happen and completely unpredictable. Yeah, that is, and yeah, in Gemeente level averaging, that is not possible.
Okay, so at what level, what kind of conclusions can you then draw from such models? On what level?
Right. So the conclusion that I would draw is that imagine that a new pathogen comes in and it spreads in a similar way that SARS-CoV-2. We of course use the parameters for SARS-CoV-2. That's why I'm saying that, making this remark. So, and people do not change their behavior. This is how it's going to look like. So it's more like a model where you can put a seed somewhere, an infection seed, and you can see how, if people don't change their behavior, there is no adaptation method in there, no how do you say, the intervention measures either, then how is the situation going to look like? And then you can put this intervention measure, of course, assuming that everyone adheres to them, and then you can also make predictions about this.
Yeah.
Perhaps I can add one comment. The work that Deb is doing with Mark is also very interesting because you can study in a better way the effect of interventions at regional scale. So that is something that hasn't, like I said, policy has been the same for the entire country. Models were not designed to really assist in what would happen if you do this in this region and that in that region. And this way of modeling could be very helpful. And in addition to that, now in this model, movement of people has been included specifically. So that will also be helpful to say more about interventions at that level. Is it wise to stop public transport, for example? The focus on that is not well supported by models, and that is possible, hopefully, with this model, if it is close enough to correct.
I think there's one more question, Johannes. We cannot hear you.
You're muted.
You're muted.
Can you hear me now?
Yes.
Yeah, thank you.
Okay, great. Yeah, well, thanks. I was triggered a bit by the comment on opening the windows. That could be a kind of butterfly effect, but wouldn't such things just be incorporated in a summary parameter like the beta or the R0?
Well, I probably would put it in the what we call infection pressure or force of infection. So that is a force of infection, basically in this case determined by whom it's whom and what kind of age group that it has, and I guess it will be a tweak on that one. But again, this is a very local effect. I mean, if you open a window of all the windows in a building, it is far too local, far too microscopic scale to really have an effect, I would imagine.
Yeah, but such micro scale things, they, at least in my understanding, they would affect the chance of infection, probability of infection, and the R0, and in that way cascade up to spreading at a higher level.
Yeah. Well, I mean, it's a fair remark. We don't really know how much cascading effect it has, in the sense that, yeah, I think you're thinking about chaos. So you make a small change in something, and then it has a really butterfly effect in what happens afterwards. Yeah, I don't really have a good idea on that.
Okay.
I don't know if Sake or Mirjam can comment.
I don't think it would happen in this type of model. I mean, it's not a model with chaotic behavior. I think it has quite a well-behaved behavior. Mm-hmm. It goes to, at some point, well, in this case, of course, the epidemic dies out once it has gone through the country, but if you would have like an SIS type epidemic, it would go to an endemic steady state.
Yeah, with probably a threshold at some point.
Yeah. Now, of course, I mean, you can say we could open the windows all over the Netherlands, then the transmission rate would go down, but that would mean then that just the speed of transmission would be reduced.
Yeah.
Yeah. Thank you very much, all. Thank you again, Deb. And I'd like to pass on to the next speaker, which is Professor Sake de Vlas. He's a professor of infectious disease modeling at Erasmus MC Medical Center, and he's going to talk about infectious disease modeling for COVID-19 policymaking, how pandemic and media waves intertwine. So Sake, go ahead.
Thank you very much. Can you see my screen?
Yeah, you can see it.
You can see it moving as well. Okay.
Yeah.
Thank you very much. Thank you for inviting me to give a presentation today. I was asked to say something about policy in the Netherlands, policy making and support by modeling. And I can already tell you that I haven't really been involved in that, at least not too much. And that's why I will focus a little bit more on how I was involved in several ways with the media, and perhaps that has caused some influence. So this is my presentation. I will start with explaining what I normally do, and that has policy relevance. Then I will say a little bit about policy making in the Netherlands for COVID-19. And then I will give some kind of chronological overview of how I was involved with the media and how that related to the different waves of the pandemic. So pandemic waves versus media waves. And I will include a little bit about our modeling. I will not make it too complex. It's the last presentation, you know. And at the end, I will look back a little bit about the role of modeling and how things could perhaps be improved. So I'm a professor of infectious disease modeling, but my normal focus is modeling tropical diseases or diseases of the tropics, and many of them are part of the group of neglected tropical diseases, NTDs. And here you see different categories, viruses, bacteria, and helminths. Helminths are worms. And these diseases often lead to terrible morbidities, not that often death, but they cause serious health impact. And perhaps some of you have heard about river blindness caused by onchocerciasis, and perhaps you also know about elephantiasis and lymphatic filariasis. These diseases are all caused by worms. The modeling that I do, so the modeling of tropical infectious diseases, is to a large extent part of the so-called NTD Modeling Consortium, which is funded by the Bill and Melinda Gates Foundation. Actually, we at Erasmus MC are the biggest group within this initiative, responsible for 6 neglected tropical diseases, but I also work on HIV, for example. Well, this work has high societal impact, and it's really used for policy making. For example, we have close collaborations with WHO in developing guidelines and their targets for the coming years. This was, by the way, not something that happened automatically. It was a little bit forced by the Gates Foundation, but now we can get along very well, and the people at WHO listen to the modelers and share ideas with them. A very important thing we do within this area is strategies for mass drug administration, because many of these neglected tropical diseases are treated by drugs, not always killing the worms, but preventing serious disease from developing. And the strategies that should be implemented, annual treatment, biannual treatment, for example, is something that we support by modeling. And of course, what we hope is in the end that this will lead to elimination of these diseases. And then the question is, how much time will that take and what are the criteria to stop? And don't forget, this is a massive exercise. In 2016 was the year that for the first time 1 billion people received a treatment for a neglected tropical disease. So this is comparable actually to what is currently happening with the vaccinations regarding COVID. And then, unfortunately, I must say, not so effective yet in African countries. Something we have done in the past year is actually related to COVID-19, because we were asked by the Gates Foundation and by WHO to make calculations of what the impact is of program interruptions due to COVID-19 and lockdowns in endemic countries. And we have done that and also calculated possible mitigation strategies, and this resulted very quickly actually in a special issue in Transactions of the Royal Society of Tropical Medicine and Hygiene. So here you see I have some experience with modeling that is influential in policy making. Now let's go to COVID-19 policy making in the Netherlands. So Deb, this is your short overview. In the Netherlands, decisions are made by the Ministry of Health, Welfare and Sports, VWS. They are supported by the Outbreak Management Team, OMT, and this team is has mainly doctors, microbiologists and virologists. It's now a long list of people. Most of them are of this type, and that has been criticized. People working on, for example, behavioral studies, social studies, economic studies are not very well represented. The OMT is led by the Center of Infectious Disease Control, which is part of RIVM, the National Institute for Health and the Environment. Modeling is very important though. The Dutch policy is strongly based on mathematical modeling. What I did was looking at an overview of the 200 most influential Dutch people in 2020, which is annually published by the Volkskrant. And this is the list. And what you can see here is that on position 2, we have Jaap van Dissel, the chairman of the OMT. So he's really considered to be an extremely influential person, also because of everything is now influenced by COVID-19. But there are many more names here in the first 50. I only selected the first 50 that have an academic background and influence policy making. Most of them are part of the OMT. But there are also a few like Ernst Kuipers, who are not part of the OMT, but are still relatively influential. He is the chairman of the Landelijke Network of Academische Centra, which is a kind of national network of academic hospitals, making plans of scaling up capacity or moving patients from one hospital to another. Perhaps you can also see here that 3 of these influential people you see on TV very often are from Erasmus MC, where I work. And actually Hans Brug, the head of RIVM, the total of RIVM, even was a colleague of mine at Erasmus several years ago. Okay, back to modeling. Because of the modeling that is used in policy, we now suddenly see even our prime minister talking about modeling terms. The R, the R-getal, the R value is mentioned many times by our Prime Minister Rutte or De Jonge, the Minister of Health. But then the modeling, who is responsible for the modeling? Well, that is a team at RIVM, the National Institute for Public Health. And in fact, very early in the epidemic, several modelers, including myself, were invited to discuss with RIVM about the various issues that should be that should benefit from further collaboration, different insights, different ways of modeling, different sources of data, different expertise that were of relevance for the modeling. And because of that invitation, different Slack groups were started bringing together this expertise. But then one way or another, it was not successful at all. All the modeling in the end occurred here at RIVM. And as Mirjam has already indicated, there is not that much transparency about what is really going on. We know it crudely, but the details of the assumptions made are not shared with the public and also not shared with other modeling experts, which I consider to be a pity. because of that, open letters were sent to a newspaper, a national newspaper, NRC, and several people asked to please use us to do something about this crisis. We are available. Please also be transparent in what exactly you're doing so that we can provide feedback. We suggested to create a national platform for corona research, but unfortunately this was usually the answer. RIVM did not have time to respond to these requests. Okay, now a little bit about the modeling we have done ourselves. This is our model, individual based, as Mirjam has already indicated. SEIR is part of it, and very importantly, it has a geographic aspect. Here you see the SEIR model. It has been explained several times. What we do include is individual heterogeneity in transmission rates. That is actually the only individual aspect. People differ in their contact rates or the risk of getting infected when they are in contact with somebody who is infectious. This is work I've done with Luc Koffeng, my partner in crime here, and this is basically how our model looks like with its geographic stratification. We have different clusters, let's say villages, neighborhoods, small towns of various sizes, and several clusters combined lead to super clusters, like provinces, for example. We started this work, by the way, 4 days after the first lockdown, so in the middle of March, and the work we have done with it is published now in scientific reports, but only in February 2021. These journals can sometimes be very slow. So regarding this geographic stratification, we assume, it's just an assumption, and we have done sensitivity analyses, that 90% of the transmission occurs within clusters, 5% occurs within superclusters, and another 5% occurs population-wide. This is a crude assumption, so that we can still do some relevant things, but this is exactly where the relevance comes in the collaboration we have with Deb Panja to make this more explicit and to quantify this in a better way. Here you see some data sources we have used. Prevalent IC admissions. ICs are also, so ICU admissions, intensive care admissions are part of the model too. Prevalent cases, new admissions, and one of the things we have used is the percentage seropositive. Based on that, we could reproduce the data of the first wave and a little bit later. The reason why we developed this model is because we were interested in quite an alternative strategy, a geographic strategy to which could be used perhaps as an exit strategy. Actually, this was also inspired by RIVM that invited several of us to work on different possible exit strategies. I must say, this was at the time we were absolutely unaware of any vaccine in sight, and also long COVID nobody had heard about. The idea of this phased lift of control, that's how we call the strategy, is to release all interventions, all measures in one supercluster, let's say a province at a time. One province at a time, and make sure that all the serious cases that occur over there are taken care of by the entire country. And that is something that could potentially be possible in the Netherlands. Of course, all the vulnerable people need to be shielded in such areas. So what happens here is this is the first outbreak. You see with this color Brabant, that was most heavily affected. And what you see here is also Brabant, it's most efficient to release interventions in Brabant because relatively many people are already immune over there. And then there is a strategy followed by other regions lifting their measures. And in the end, this is a strategy that will take quite some time, by the way, but we will stay under the threshold of what the country can deal with regarding ICU admissions. We also looked at a more optimistic strategy where this capacity would be doubled over time, and then of course the strategy can be shortened. Again, this is something we just did as a thought experiment at the time that nobody could even imagine that vaccines would be available so rapidly. Okay, so this is work we did shortly after the first wave, and this was picked up by a newspaper with this interesting heading. I saw the first results and I thought, holy fuck, the timeline. And that is one of the main issues of what this exercise indicated. Without vaccines, it would take a long time before we would conquer COVID-19. Of course, this also led to some reactions of a letter, a critical letter, not using these kind of words. Actually, if you go back to the website of NRC, you can still find this paper, but with a slightly changed title. Because of this, many more media followed. There were not that many talking heads, certainly not modelers on TV, on the radio, talking about these kind of things. The people from RIVM did not go to talk shows, so we were invited and we accepted a few of these invitations. Here you see Luc in Eén Vandaag, and this is exactly the figure that I showed to you. So we were able to show some modeling on national TV, even at prime time. We also went in to Op 1, but also on different radio channels, including Omroep Friesland. I come from the north of the country, so I could even explain the things in Frisian. Interesting enough, our story was picked up also by some regional newspapers, and this is Brabants Dagblad, and they got the news that in our strategy, it would be nice to start with lifting measures in Brabant. They already suffered a lot, and what you see here is a very nice description of how things would look like at the 1st of May in Brabant. Everybody could be on terraces. You see a nice photograph here, so beautiful news for Brabant. However, a couple of days before that, I received an email from someone from the north who asked me if the levels go down if the transmission levels go down to very low values, wouldn't it be reasonable to lift interventions in the north first? And my short reply was, I think that's reasonable. And just coincidental, in the Leeuwarden Courant, at exactly the same day, the North can first stop their lockdown, and this is my quote, I consider that to be a logical option. So at the very same day, you could read in the Dutch regional newspaper that Brabant should lift first, but that was of course based on our strategy, and that the North could lift their measures first, but that was something completely different. That was because the North was less intensely affected by interventions. Okay, some other things we did with our modeling was focusing on the second wave. So now we have dealt with the first wave. You can see here what RIVM predicted, and this, for different scenarios, this was the prediction, and only here, you see an arrow here, perhaps a second wave could occur. That was at that time what RIVM predicted, and it was also presented to the government on the 7th of May by Jaap van Dissel in his regular technical briefings. But based on our model, we had quite different conclusions published in Trouw. So you already saw that we could mimic this part of the pandemic, and we needed to assume that during the lockdown, the rate of contacts was 20% of normal. That did everything regarding this very rapid decline. But if we would lift measures and just return to 30% or just 35 or just 40%, new waves would occur, which led to the conclusion for us that it's quite likely with the interventions that were planned to occur after the first lockdown that a second wave would be inevitable. Well, we all know that this second wave occurred, and I don't want to say that we were right and our RIVM was wrong, because there were several other factors that played a role, like in introductions from abroad during holiday period. Perhaps seasonal effects played a role that were not included here yet. And I must also admit that these waves occurred very rapidly, whereas it took quite some time, the entire summer, before the second wave occurred. But it was still fun to have this conflicting news. Following that, I have a few quotes because the newspapers still wanted us to say several things, but it was a relatively low tide. So one of the things we said, or I said, was that the second wave is perhaps just a small wave. Something about lifting interventions, probably it would not happen too soon. This is modeling through to the next wave by lifting interventions and then making them a little bit stronger again. This was the kind of information we provided. Something we also did was commenting on other studies. Quite often journalists came to us to provide a view about that. So for example, a paper by Mirjam Kretzschmar about testing strategies. It was not presented today, but I was very positive, of course, about that paper, about how testing strategies should look like, impact of face masks, and something newspapers were extremely interested in was comparing countries. So one of the quotes I'm a little bit less proud of is a quote about the fact that the Belgians had relatively high death rates, which was mainly the consequence of the way they counted everything. And one of the things I said that, as a matter of speaking, anyone who was a little bit snotty at the time of dying was included as a COVID case. I'm not so proud about that quote anymore. Furthermore, I also expressed the coincidental effect. Actually, that was something we even discussed at the end of Deb's presentation, that random effects played a relatively big role, and that could also have caused differences between countries. For example, in the Netherlands, the fact that after a holiday period, many people introduced from Italy COVID into to the Netherlands, which went together with Carnival in the south, and that was probably one of the reasons why it spread so rapidly over there. Furthermore, there were many empty statements. What will happen if we do this and that intervention? I don't know, was my reaction. Or I can perhaps do some calculations, but then you need to tell me how the behavior of the people is going to be. Everything ended up in the newspaper. It surprised me quite a lot. Okay, I was also involved a little bit in some other policy making. I already mentioned the name of Ernst Kuipers, who is responsible for the care of serious patients and people at the ICUs and how they are spread over different hospitals. And his team developed a very simple model, a kind of renewal model in weekly steps. So in weekly steps, you have a number of new cases being replaced by 1 week later other new cases. And it's a kind of R value. If it is larger than 1, it will increase. If it is less than 1, it will decrease. And that model worked quite well for the first part. So they assumed a declining R, which is reasonable because more and more people developed immunity, and the percentage of the population still susceptible to infection is decreasing. So R will automatically decline a little bit. But here we see a lift up because of this Alpha variant, the British variant, the UK variant, which has a higher R0, and because of that it increases. But after some time we will have the same decrease due to immunity developing. However, and that's where I came into this picture, it happened much faster, which is, of course, what you see here is the number of COVID patients at the ICU because of the effect of vaccination on the disease development. And because of that, the curve turned downwards much faster. But even then we needed to make an update because the vaccination also clearly had an effect on transmission. And this is the last one I made. So the last dot here is at the beginning of June, and I think we're still following this trend that by the end of June we will not have more than 200 people at the ICU. I think we have about reached that level right now. Okay. Then another example of where in what I was involved is the curfew. Was the avondklok necessary? And this was all triggered by something Ernst Kuipers. You have heard that the name. He is also the director of Erasmus MC. So in the end, he is my boss. And he said the curfew was not effective. For the simple reason that there was nothing seen in the general trend. This is the moment the curfew started. Trends were downwards. Of course, it takes some time before you have fewer cases in hospitals because of a time delay, but nothing could basically be seen, and that led to his conclusion that it was not effective. Well, many people criticized him because we all know that at the same time this British variant, this Alpha variant, also came up, and perhaps the two processes balanced each other, or and we can even see this increase because of the British variant. We even saw a temporary increase for some time. He made this statement because Ernst Kuipers has an independent role here. He's not part of the OMT, and I know he has also said that on TV that he was quite critical about some of the RIVM calculations, and especially this one. This is a curve indicating what would happen without a curfew. And what you see here is a very rapidly increasing curve. They call it the hockey stick. And this initially led to a lot of alarm in the people in the hospitals, what to do, and we need to change our policies and strategies and everything. But they decided to ignore this. They couldn't believe that this would happen. So I noticed that not always the advice from the modeling teams were taken into account. Still, the question remains whether or not this curfew was effective. And I have one intermediate slide about perhaps an explanation why this curve increased so rapidly. And that is because Luc again, and I believe that standard SEIR models are often too pessimistic, and we have illustrated that with our model with only 10,000 individuals and 10 different clusters. And this work will be published in the Royal Statistical Society somewhere in the future. And what you see here is 3 different types of models. First, a model with a homogeneous population. This is basically the RIVM model, but the RIVM model has an age stratification. Then we include inter-individual variation, so this heterogeneity, that individuals differ from each other in the risk of getting infected. And because of these clusters, we also included assortative mixing, that people with higher risks or more contacts, one way or another, cluster in the same communities. This is, by the way, still a theoretical example. So what we did was reproducing these 2 observations at the beginning of an epidemic, and then see what happens for the different models. And you already see here that the model with a homogeneous population predicts a much higher level, which is logical, because our model with heterogeneity, in a model with heterogeneity and assortative mixing, the initial spread is largely caused by those individuals that have the highest risk, that have the highest transmission rates. And they disappear after some time, and the remaining population is simply less vulnerable, leading to a higher peak. We also see this occurring if we look at a longer period of data. This is again the situation before interventions, and here we have control measures occurring. And if you then make predictions of what is going to happen, so you first estimate this beta parameter, then you estimate the effect of the intervention, and the 2 combined lead to similar patterns of what will happen if you maintain this intervention. However, if you include something like releasing interventions, if a level of 100 infectious cases is achieved, then you will see that there will be a second wave in this homogeneous population. And this is because in a homogeneous model, at the beginning or at the end of an outbreak, individuals are all vulnerable individuals, susceptible individuals are all the same. And that is not the case in a model with heterogeneity and assortative mixing, and most likely in reality that's also not the case. So I think that this explains to some extent why sometimes the RIVM model is too pessimistic. Now, something about this curfew again. And first of all, we have to look closer at the data regarding the different variants. We call that the Kiem surveillance data. So these are tests done by different labs in the Netherlands, and to check what the fraction of the British variant is. And here you see the observations nationwide. And during the first few weeks of observations, this was the general trend. And that is also part of the explanation why the RIVM was so negative about what would occur without a curfew, without additional interventions, because this trend would continue basically like this. And that has been criticized a lot, because other studies were conducted, like in Twente and in Lansingerland, at the same time that had much lower levels. But the interesting thing is that over time, these trends plateaued, and then later on started to increase. And this brought me to an idea that perhaps this could be used to say something about the curfew. Because from information that I had, I was told that Amsterdam was mainly responsible for the first observations here regarding the presence of the British variant. And Amsterdam has, of course, close links to the United Kingdom, so probably early and many introductions. And later on, I had the impression that more labs were added, and because of that, this could lead to a plateau. So if you would fit a kind of curve here, this could be the curve for Amsterdam, not as negative as this one, but the blue curve, and this could be the curve, for example, for Twente. Now I know, because I did receive data from RIVM about this, that this picture is not true. Different locations, or let's say all regions of the Netherlands were present in these data. And surprisingly, there is a plateau to be seen for all different regions. And it's not completely clear to me, but perhaps it has something to do with these different locations, that initially the variant may spread at some location, and then it takes some time before it is introduced in another location, in another cluster. Perhaps that is the reason for this stagnation. So it could be interesting to dive deeper into this. Anyway, we do know that locations differ quite a lot in the level of the British variant, and areas like Twente and other areas, other remote areas, had a very late introduction of the British variant, and at the moment of introduction of the avondklok, the curfew, the levels of the British variant were very low. So if the curfew were effective, we would have expected a drop in cases. So let's see if that is the case. And that's what you can see here. This is different trends for different regions. We have 10 regions in the Netherlands with data regarding the number of new cases with COVID in the hospitals. And I assumed that these areas were relatively early, the west, the southwest, and the northwest. These were somewhere in the middle, the south, and also the middle of the country. And these remote areas were relatively late. Zwolle, the east, the north, and Twente. For Twente, we even know from a different study. So let's see if we can find this drop in the level of numbers of new cases. This was the moment of introducing the curfew. This is the moment where the first effects should be seen, and everything was scaled to 100 cases. And nowhere you really see a drop. So this led to me to the conclusion that the curfew had little to no effect, and there is literature, and partly based on this literature, it was introduced in the Netherlands, but perhaps something that worked for other countries did not work for the Netherlands. Now my final slide, to look back a little bit. This is also summarized in another piece in NRC. And first of all, and I still need to repeat that, there is a lack of transparency in modeling for COVID-19 policymaking in the Netherlands. We have offered our services. I still think that even if there is a difficulty with sharing individual information, perhaps a kind of interactive peer review could be done. Furthermore, it would be good to focus on validation of the predictions that have happened in the past. We can learn from that. Furthermore, we also know that modeling was not used for all the policy making in the Netherlands. I have two examples here. First of all, the Dutch vaccination strategy. There was an advice from the Gezondheidsraad, which is also influential, to start with the most vulnerable people. But because of the responsible people in the hospitals, we still decided to start the vaccination strategy with the people in the hospitals taking care of vulnerable cases. Another thing that has happened is that there were no flights from the UK anymore at the time that the British variant was spread all over the country. So this is typically something that was just done with no particular reason. Any modeler could tell you that this would not be very effective. I also would like to repeat this. If you want to make predictions, it's very important to first estimate the behavior of the population, and then you can really make predictions. And we have simply seen that the same measures, the same degree of lockdowns in the first and in the second wave had quite different results. Finally, I also hope that we are now moving towards the end of the tunnel. And then it's time to look back and to evaluate measures like I did here crudely for the curfew. I think we need to do this at a larger scale because we need to learn from it. You never know if COVID returns with a different variant or some other virus, and it would be good to know what worked and what did not work very well. Still, I do think that this should be done by an independent party and not by the same teams that have made the predictions on which the policies were implemented. That ends my presentation. Thank you very much.
Thank you very much, Hake. We're a bit over time, about 10 minutes. So I would suggest, 1-2 short questions, and then we'll wrap up. So who? Johannes, go ahead.
Yes. One question, and thanks for the talk. You tell it in an exciting way.
It was exciting. It was a very special year.
And I'm glad you did some of the things, but I have one question remaining. You mentioned inter-individual variability in, I guess, susceptibility to the virus. And I was curious whether models, your model or maybe other models, also take into account inter-individual differences in connectivity, because I would guess at the beginning of an epidemic, the most connected individuals get infected first, spreading most, giving a kind of overestimate of the whole population infection rate.
Yeah. Like I said, we have used a relatively simple model, an SEIR model, and it basically has, like Deb explained, one parameter that is really free for us. It's the beta parameter. And this beta is a combination of a transmission rate or a contact rate or the risk of getting infected if you are in contact with somebody. It's a combination of everything. So it includes all these different factors. So we have one beta, which is an average value, and we assume that individuals have on average a multiplier, have a multiplier that is on average 1, but it can be higher and it can be lower, and that automatically leads to selection of individuals. If you talk about this connectivity, so very explicitly networks, we do not have networks in our model, but it is captured to some extent by the different clusters, the villages and the cities that we have in our model. But I do hope that this feature will even become better in the work we're now doing with Deb and his team about including more network aspects and also a more explicit geographic stratification.
Yeah. Okay. Very good.
Thank you.
Pleasure.
Connects nicely to Deb. Final question for Deb.
Sorry, Hank, there's a question posted in the chat already.
Sorry, I saw that, but that's very long. Well, if I read that, it takes 5 minutes, so I'll skip it. Sorry. For people
can summarize it.
It's actually getting back to the question that Rob asked about the validation of the model that we are making, and it seems to me from now the overview that I have from Mirjam and the overview presentation you made of the policy, it seems to be a general problem of epidemiological model validation. So what can one actually do to validate models for that matter?
There is always a random aspect, you never know if you capture that correctly. In the Netherlands, we had this start of the epidemic in Brabant, where Carnival and a holiday period with people returning from their ski vacations introduced the infection. These kind of aspects occur. You can never reproduce it completely. A validation is by stratifying your model into, for example, different regions and see if one overall model with crude assumptions works for the different locations of which you know how they differ from each other. That is a method for validation. But of course, the best validation is to make a prediction and check what has happened. Yeah. But, you know, if you make a prediction of an intervention, all interventions are linked to people's behaviors. And if it doesn't work, there is always an excuse that the behaviors of the individuals were not according to expectations. So is the model wrong, or is our impression of how the behavior would look like wrong? So it's never going to be perfect. But hopefully the model is good enough to compare different interventions, and that is mainly what we wish to do. And very often, and that's also with our facelift strategy, for many different assumptions, the general outcomes of this strategy remain the same.
Okay.
Thanks. Yeah.
Thank you very much. So I'd like to wrap up and thank all the three speakers for the very nice talks. I'd also like to thank Deb Panja, who originally, suggested this workshop and also organized the speakers, etc. And to Chinji and Natasha and Robert maybe also to, arrange all the organization and communication, and etc. So thank you all very much. I'd like to end with what Chinji mentioned also, that there will be a call by Son and Wei. And the title is Prevention in Transition, Embracing Complexity and Strengthening Resilience. That has been announced. The call will open later this year, and the link is in the chat. So that's a preliminary description, right? Chinji put it in the chat as one of the first messages.
Yeah, I can do that again.
So anyone interested, and I think there's several of those who are here will be interested. I hope there will be, also quite a decent amount of money available and not very incidental, short-term funding. So you can start, very long-term projects on this sort of work, because it's going to be important also for future pandemics, I guess so. So thank you all very much for being present. And, it's the last activity of the center in the academic year, and we all start to open up again in September, and hope to see you then in person in the center at that time. So again, thanks very much and have a very nice day.
Yeah, thank you.